everyone. Welcome to IPA's Best Bets webinar on small quantity lipid-based nutrient supplements, or SQ-LNS. My name is Doug Parkerson, and I will be hosting today's webinar. I'm a senior research scientist at IPA and lead our Path to Scale research team. Joining me today from the IPA team are Carla Peterson, our Director of Scaling and Global Policy. You'll be hearing more from her about IPA's Best Bet report in just a minute. We also have Savannah Henderson, the Associate Program Manager on the Path to Scale research team, and Kara Vu, Senior Communications Director. And I can't overstate the role in making this webinar happen that each one of these folks played. So before we dive in, a few housekeeping items. Okay, we'll be having presentations and a panel discussion focused on scaling SQ-LNS programs. If you'd like to ask questions during the event, please submit them through the Q&A function and share your name and affiliation if you're comfortable, so our panelists will know who the question is coming from. And feel free to ask questions throughout, and my co-moderators and presenters will try to answer as many of them in the chat as possible. We will also select a few to be answered by the presenters and the panelists during the event, depending on the time that we have. So this webinar is being recorded, and we'll make it available after the event. We appreciate your sharing the link with colleagues and partners you think might be interested in these topics. And please get in touch with Kara Vu or Savannah Henderson if you have any technical difficulties. So before diving in, I do want to just clarify two terms that you will be hearing quite a bit, some of you more familiar than others, I imagine. But the first is stunting, and stunting refers to a child who is too short for their age. It's identified and measured based on children's length or height in relation to their age. So a child is considered stunted if their height for age Z-score is more than 2 standard deviations below the WHO Child Growth Standards median. So that's stunting. And then you will also hear a bit about wasting. So this is acute malnutrition, refers to a child who is too thin for their age. It is identified and measured based on children's weight in relation to their height. The child is considered wasted, again, if their weight for age Z-score is more than 2 standard deviations below the WHO Child Growth Standard median. Okay, today's agenda, we have a packed schedule here. So we will start with Carla Peterson, IPA Scaling Director, will kick things off with an introduction to the report, to the Best Bets report, and conceptualize how the topic of today's discussion connects with the report and IPA's commitment to discovering and advancing what works to improve the lives of people living in poverty. This will be followed by Kathryn Dewey from UC Davis, presenting about the evidence or making the case for SQ-LNS to prevent child malnutrition. I will then share some results from IPA's work in Zambia on SQ-LNS, recent work, followed by Christine Stewart, who will share research priorities from the SQ-LNS Task Force. And then Philomena Irene from UNICEF will share their experience in Nigeria. We will then have a moderated discussion and finally a call to action. We got a lot to cover. And so without any more delay, I would like to pass the mic over to my colleague, Carla Peterson, to get things started.
Thank you very much, Doug, and good morning or afternoon to everyone, depending on where you're joining from. It's exciting to see so many people interested in Best Bets and SQ-LNS in particular. And in this presentation, as Doug was mentioning, I will walk you through our motivation behind the Best Bets report, which we launched in November, as well as our approach for moving these promising innovations forward along the path to scale. So I'd like to start by reminding people how the last years have witnessed what has been characterized as an evidence revolution, with significant increase in the amount of funding and the number of impact evaluation studies that are relevant to development policy and programming. As this graph shows, as an example, impact evaluations have spiked to over 10,000 as of March 2022, compared to only less than 100 in 2000. And yet the number of evidence-based programs that are operating at scale is still relatively small and only addresses a slice of the challenges that vulnerable populations face. Examples of these well-known or established innovations that are backed by strong evidence and have proven successful across different contexts include cash transfers and universal basic income, the graduation approach, teaching at the right level, and structured pedagogy. And over the course of several years, coalitions of funders, researchers, implementing partners, of which IPA and many of you have been a part of, have built the evidence-based and delivery model for these interventions and advocated for their implementation at scale. And there is strong interest in the evidence to policy community today in identifying and investing in more interventions of this sort that can effectively address problems that affect the lives of people living in poverty. But as we've seen from the examples described before, identifying interventions that are both effective and can impact more people at scale, which we are referring to as established innovations, requires significant resources and time. So we must strategically decide, based on the best evidence that we have today, where our investments can be more transformative in the search for the established innovations of tomorrow. In other words, out of the thousands of innovations that have shown some success through rigorous evaluations, how can we identify the ones that hold the greatest potential to move upwards along the path to scale and become the next generation of established innovations? To answer this question, IPA sectoral experts and network of academics from across the world reviewed hundreds of studies, both within and outside of our portfolio, looking at the amount of evidence, the impacts observed, the cost, and other scalability factors, as well as the levels of partnership engagement. Based on this exercise, we identified nearly 50 path-breaking approaches as being on the path to scale, either as proof of concept innovations, interventions or policies with rigorous evaluations demonstrating the success in one context, exploratory innovations, that is, interventions with limited or conflicting evidence across different contexts, requiring further research to understand their effectiveness, target population, and implementation conditions. Emerging innovations, that is, interventions supported by solid evidence across contexts, but where questions still remain about cost-benefit, delivery models, targeting, and long-term impacts, among others. And established innovations, which, as I mentioned before, have been proven successful across different contexts and are already operating at scale. But as previously mentioned, we also consider the levels of partnership engagement for each of the interventions. So for exploratory innovations, partnership activities are required to expose potential implementing or funding partners to the program and to make sure that the research is addressing their questions. For emerging innovations, partnership activities are targeted towards implementing these interventions to address the remaining questions. And even for established innovations, coalition building is still required to bring the delivery of these interventions to mass scale. Emerging innovations, which sit in the middle of the path to scale, are our best bets for the next generation of evidence-based programs that can make an impact at scale. Our expectation is that with further research and policy engagement, some of the best bets will become established innovations, or smart mice in the future. I will now delve a little bit deeper into the concept of best bets. So best bets are innovations that IPA sector experts believe hold the most promise for making an impact at scale, taking into account the amount and quality of the evidence, that is, evidence of effectiveness as supported by multiple studies in different countries, sizable and/or wide-reaching impacts, and other scalability factors, such as the cost, the ease of implementation, and the existence of funders and/or implementers that are engaged and may be ready to scale these interventions. But they still require additional research and in some cases more commitment from implementers or funders to push them forward along the path to scale. Examples of the remaining questions have to do with optimizing for cost benefit, improving delivery by simplification and leveraging digital tools, and testing for impact and validity in other contexts and within the target population. I will now briefly walk you through SQ-LNS, one of our best bets, to illustrate this approach. So SQ-LNS are food-based supplements designed for the prevention of malnutrition in children 6 to 24 months of age. In settings where vulnerable populations are likely to have nutrient gaps in their typical diets and multiple micronutrient deficiencies, these supplements can optimize health and growth in children. The evidence for this innovation and the size of the impact are very strong. An analysis of 14 trials conducted in different contexts found that consumption of SQ-LNS among children decreased stunting by 12%. And given the evidence, a coalition of nutrition leaders, including UCDs and UNICEF, represented here, have called for the scale-up of SQ-LNS. And yet further research and party activities are required to support national governments to integrate SQ-LNS with other child nutrition interventions, improve delivery in diverse settings where impoverished families live, reduce costs by targeting the most vulnerable communities, and scale up SQ-LNS programs. So following this approach, we identified 14 best bets or emerging innovations. I will now give you a few seconds to go through this list of innovations. The idea behind the Best Bets report is to go beyond evidence sharing and to inspire coalitions of implementers, researchers, and funders to capitalize on existing knowledge of what works to address some of the world's most pressing problems, and to invest in high-impact research to answer the remaining questions for these interventions, so we can impact the lives of millions of people living in poverty in a cost-effective way at scale. IPA will build and support these coalitions of implementers, researchers, and funders to move best bets forward. We want our support to be complementary to the work other partners and peer organizations are already doing, and catalytic, where not many organizations and resources are currently involved. Depending on each best bet, the support could include synthesizing and disseminating evidence, developing research agendas and implementing projects to address the remaining questions, partnership activities to scope for scaling opportunities and replications in other contexts, technical assistance to guarantee implementation with fidelity to the evidence, and fundraising for pilot development and finally at-scale implementation. SQ-LNS is a very good example of the broad range of support that IPA can provide to move best bets forward. We connect across researchers, experts, and practitioners on a series of activities in research, partnership development, technical assistance, and fundraising. Examples of these activities include building the evidence base with potential scaling partners in Zambia, which we will hear more about from Doug, establishing deep partnerships with a network of partners in Zambia for the long-term success of the intervention and connecting regularly with key stakeholders in the ecosystem, providing technical assistance that ensures that partners are learning alongside the research, and making sure that we're building capacity with partners for evidence-based implementation. And finally, mobilizing resources for learning, informed scaling, and also to resource the coalition that can eventually implement SQ-LNS in Zambia as an evidence-based scale program. If you're interested in learning more, you can find the IPA's Best Bets initiative in our website, including the report. I'd also be happy to connect and discuss how together we can move Best Bets forward. And you can also follow us on social media to stay updated on our initiative and future webinars like this, showcasing the different interventions highlighted in the report. Thank you, and now I will pass it back to you.
Thank you, Carla. So next up, I would like to introduce Kathryn Dewey, the Distinguished Professor Emerita of Nutrition at UC Davis, and a member of the steering committee for the SQ-LNS Task Force, to share the case for SQ-LNS to prevent child undernutrition. Okay, the floor is yours.
Well, thank you very much. It's indeed an honor to be able to participate in this webinar, and I will be talking about the evidence base for SQ-LNS as well as cost and cost effectiveness issues. Sorry, my slide is not advancing. I don't quite know why. Let's see. Okay, so we have a large challenge in meeting nutrient needs in children between the ages of 6 to 23 months of age. Globally, less than 30% of children in this age range meet the criteria for a minimally diverse diet. And this increases the risk of growth faltering, anemia, and impaired development. And a key barrier in this area is the lack of affordability of nutrient-rich complementary foods. I'd like to put into context where small quantity LNS fits within the family of lipid-based nutrient supplements. And all of these products provide energy, protein, multiple micronutrients, and essential fatty acids. But the daily ration varies in size depending on whether it is designed for prevention or treatment of child undernutrition. So small quantity LNS on the left, which is generally about 120 calories and only about 4 teaspoons in the sachet, is designed for prevention. And on the far right, we have the products that are designed for treatment of moderate or severe wasting or being very underweight for length or height. And those products are much larger, about 5 times the amount per sachet than that we have in SQ-LNS. So as I mentioned, SQ-LNS is designed for prevention of undernutrition. It contains micronutrients in a dose of about 1 recommended dietary allowance per day. And the ration size is small on purpose in order to avoid displacement of breast milk and nutrient-rich foods, ensure that all targeted infants and young children can consume the entire ration in one day and thereby receive the intended doses of micronutrients, and to minimize cost. There have been several meta-analyses of the impact of SQ-LNS. We published a paper in 2019 on the effects on child mortality, and 12 of the 13 trials in the primary analysis used small quantity LNS. And we demonstrated a 27% reduction in all-cause mortality in this age range. In 2021 and 2022, we published a series of papers from a meta-analysis looking at effects on child growth, anemia, micronutrient status, and development. And this involved 14 different trials representing 9 countries and more than 37,000 children. I won't go through all the details of that, but I will mention that most of the trials began supplementation at about 6 months of age, and the duration varied, although many of them continued supplementation for 12 to 18 months. I'm going to focus on the results for stunting because this webinar is focused on that. This shows what we call as a forest plot of the effects on the stunting prevalence ratio, which is the prevalence of stunting in the intervention group that received SQ-LNS compared to that in the control group. So when the prevalence ratio is less than 1, it means that there was a protective effect or a reduction in stunting prevalence. And you can see in this slide that of the countries included, almost all of those prevalence ratios were less than 1, favoring a positive impact of SQ-LNS. And the pooled prevalence ratio at the bottom was 0.88, and that indicates a 12% relative reduction in stunting at inline. We also found an effect on severe stunting, and that is defined as a height for age that's less than 3 standard deviations below the growth standard median. And in this case, there was an even larger effect. The pooled prevalence ratio indicated a 17% reduction in severe stunting. I won't go through all the other outcomes, but this slide illustrates some of the impacts that we saw across multiple outcomes, including mortality, wasting, severe wasting, which was reduced by 31%, the effects on stunting that I mentioned, a 64% reduction in iron deficiency anemia, and a 16 to 19% reduction in developmental delay across many different measurements. And for most of these outcomes, the evidence was graded as high certainty due to the large number of trials and large number of children included. Now, one of the advantages of doing the individual participant data meta-analysis is that we can look at what we call effect modifiers. In other words, who might benefit most from this intervention. We examined both study level characteristics on the left, including region, stunting burden, malaria prevalence, community water and sanitation, duration of supplementation, child age at enrollment, frequency of contact, and compliance with the intervention, as well as household, maternal, or child level characteristics on the right. In general, we found that there were benefits seen across nearly all strata of community level, household level, and individual level characteristics, which means that all children have an opportunity to benefit. We did, however, see some effect modification by certain characteristics. For example, in households with a lower socioeconomic status and in communities with a higher stunting burden, there were greater effects on the developmental outcomes. In communities with poor water and sanitation conditions, there were greater effects on severe wasting, but lesser effects on iron deficiency anemia. And in households with more severe food insecurity, there were greater percentage point reductions in acute malnutrition and underweight. So targeting on the basis of population level, socioeconomic status, or burden of undernutrition may be worth considering. And such settings are also associated with a greater risk of infection or inflammation, which in some cases could constrain a response on outcomes like iron deficiency anemia. And for that reason, we recommend co-packaging with other types of interventions. This evidence base has led to a series of events represented here in this slide. In 2021, SQ-LNS was added to the list of evidence-based interventions to improve maternal and child nutrition in the Lancet series that focuses on that topic. In 2022, there was a small convening of interested stakeholders in Washington, D.C. to discuss scaling up, and several representatives from various organizations published a statement in Nature Food in early 2023 recommending the scaling up of SQ-LNS. And lastly, last year in the fall, SQ-LNS was included in 2 sets of guidelines from the World Health Organization, one for complementary feeding and one for prevention and management of wasting. So now I'd like to turn to the issue of cost effectiveness. And first I'd like to just define a few terms so we're all on the same page. First of all, cost efficiency is a term used to describe an estimate of the cost per unit of output, for example, cost per child year. Cost effectiveness is the cost per unit of outcome when you measure the outcome in terms of things like deaths averted or cases of stunting averted. Cost utility is an estimate of the cost per disability adjusted life year, or DALY, averted. And DALYs reflect the current value of future years of life lost and or years of healthy life lost due to living with a disability or a disease. And lastly, cost benefit is an estimate of the total cost relative to the monetary value of one or more outcomes. One of the working groups for the SQ-LNS Task Force focused on cost and cost effectiveness data and compiled information from projects in several countries that had detailed information on the actual distribution and cost in programmatic settings. And this included the studies shown in the table here. The method for assessing cost effectiveness in these trials was a little bit different. On the right, there were 4 in which this was possible. Some of them based cost effectiveness or DALY calculations on mortality, anemia, and developmental disability. And 2 of them based it on outcomes related to wasting and severe wasting. So from all of that work, which I won't have time to describe in detail, we concluded that the total cost of providing SQ-LNS daily was about $50 per child year in most of the case studies, with product cost averaging about 60% of that total. That means that the total cost for a program aimed at all age-eligible children in a given country will be high. However, it's important to keep in mind that the product price may decline with global scale-up, and there are already some promising innovations in development that should accomplish that. And also, policymakers may choose to target to the most vulnerable communities or to devise cost-sharing strategies that will bring down the total cost that they have to support. Now, in the studies that I mentioned, the cost per DALY averted ranged from $253 to more than $1,000. And the higher cost was in the less efficient program, for example, in Burkina Faso. In the more efficient programs, which were the other 3 examples, the cost per DALY was less than the GDP per capita, as you can see in the table below. And that's a yardstick that's often used to estimate whether an intervention is considered quite cost effective. So in the technical brief that we developed, we concluded that the current evidence suggests that provision of SQ-LNS can be very cost effective if properly implemented and integrated into an existing delivery platform. And that type of integration allows for taking advantage of existing human resources, sharing overhead, and training and supervision costs. Now, I'd also like to mention that there is cost-benefit evidence that's been published. For example, a paper for the Copenhagen Consensus published last year looked at this question, and they looked at targeting this intervention to the poorest 60% of a population in the 40 low and middle income countries with the highest rates of child stunting. And they found a benefit to cost ratio of 13.7 to 1, which is very good. So if you're interested in more details, the technical brief is available at our website. And I'd like to thank the members of the Cost and Cost Effectiveness Working Group for their hard work on that analysis. Again, more information is available at the website, which includes frequently asked questions, research updates, and operational guidance. And with that, I'd like to turn it over to the next speaker.
Thank you, Kay. Bear with me just a sec. Okay. All right, thank you. So Kay shared the high level meta-analysis information, and I would like to now share about work that IPA has done with colleagues in Zambia on the impact of SQ-LNS as part of the child growth or on child growth in the ZAM charts RCT. So this is work with a number of collaborators, including Gunther Fink at Swiss TPH, Peter Rockers at Boston University, Dorothy Sikazwe at the Ministry of Health in Zambia, Lindsay Locks and Jackie Glauer also at BU, and Chiza Kumwende at the University of Zambia, along with stellar project management and data collection from Tamara Bilima Mulenga, Mpele Chembe, Stephanie Ajuvo, Mwinga Chilo, and Savannah Henderson. And this work was funded by St. Antonius Foundation Projects with support from the CRI Foundation. So let me jump into the motivation for this. So stunting still remains quite high in Zambia. From the latest DHS, 35% of children were stunted nationwide. And an earlier study from Fink et al. In Eastern Zambia showed one promising intervention was home-based growth monitoring or growth charts. And we had an opportunity to test the growth charts at a larger scale in a diverse set of districts in Zambia and to compare that to SQ-LNS. And this presented an opportunity to explore other related questions on consumption, compliance, willingness to pay, child development, gut microbiome, and environmental enteric dysfunction, and infant and young child feeding programming. And we also had, through IPA's presence in the country, relationships with the Ministry of Health, where there was a lot of interest in these topics. So these are the three districts that the study, where the study was: Mansa district in the north, Choma in the south, and then around the capital in Lusaka. There were 4 arms to this study: one control group, one group that received the growth charts only, one with SQ-LNS only, and then a combination of the two. And each of these were in about 70 clusters. And a cluster, the unit of analysis was the caregiver child dyad. And these clusters, a cluster was a census enumeration area. And we started by identifying in approximately 95 of these enumeration areas as clusters. And then we selected 95 from each of the districts, and then visited each of the households in those districts to identify children that would be approximately 6 to 11 months of age at the beginning of the study. So there were 3 main objectives of this study. The first aim was to assess the impact of growth charts installed in children's home on children's physical growth. The second was to assess the extent to which growth trajectories can be modified through the provision of SQ-LNS. And the third was to assess the growth trajectories through joint provision of SQ-LNS and home-installed growth charts. A few secondary objectives. 1 second. A few secondary objectives were to observe the feeding practices within the household. So once the SQ-LNS entered the household, understanding the compliance and the feeding patterns around that, as well as other dietary and feeding practices in the household. A second was to assess the willingness to pay for SQ-LNS among the participating households. And finally, assessing the gut microbiome and prevalence of environmental enteric dysfunction or leaky gut syndrome. Okay, so this is just a quick timeline. The census and baseline happened in between April and July of 2021. The intervention was then launched in November of 2021 and continued until May of 2023. And the inline survey occurred last year between June and September. So a quick note about the interventions. We're not focusing as much on this one, but there was a study arm on the growth charts. This is an image of the chart for girls and the chart for boys on the right. And the measurement space there in the middle is designed for caregivers to be able to stand their child up against the wall and line them up with their age and see how their growth is advancing. The SQ-LNS you've heard already quite a bit about. We use the NutriButter Plus product from Nutriset. And this was delivered to participating households on a monthly basis. They either picked it up at a central place, or in some cases it was delivered to their home. They would receive a full month's supply of a daily dose for their child. I wanted to mention this was some of the messaging that went along with the provision of the NutriButter. And so this included, a description that the NutriButter was made from peanuts and had nutrients to support healthy growth. And it was emphasized that NutriButter is not a replacement for breast milk or other foods. And also kind of encouraged caregivers to continue to breastfeed the child and provide a diverse diet. It was also explained that they could mix one sachet with the child's meal, or the child could eat it directly, as described on the packaging, and to aim for feeding one sachet per day to the child. The other messaging, I think, it mentioned that the NutriButter is meant only for the identified child participating in the study and should not be given to other children in the household or other family members. But there, of course, was no enforcement mechanism to that. But that was the messaging that was given. So I'll just kind of move through this. Okay. Let's get to the results. Well, first of all, these are the characteristics of the participating households. I just want to highlight here that the average age of children at the beginning was about 6 months old. And then you can see here the caregiver information, but I wanted to also just kind of point out that around when most of the children were 6 months of age, the mean height for age z-score, or length for age z-score, was about -1. But by the inline, it had grown to 2, and that's typical as children are weaned and begin complementary feeding, you often see an increase, but this is a high level of undernutrition in this area. So getting to the results, in the red box, this is the SQ-LNS only, and what we have here, we see significant effects on weight for age z-scores, about 0.17 standard deviation, height for age z-scores, 0.21, and then a measure of hemoglobin and child development measured through the GSED of 0.28 standard deviations. And the other arms are shown there as well, which were less effective. Another way of showing these results is on the odds ratio, or the of stunting. So being to the left of this line means that the chances of being stunted are reduced, and so we see a over 30% reduction in this case in the odds of stunting. So the GSED scores are, I wanted to put those a little bit in context. So that's the child development score. So our analysis suggests that 0.19 standard deviations for the growth charts and 0.28 increase in child development for SQ-LNS. And so how large what do these mean? How large are these? And so in the field of child development, the home visiting programs are the kind of the gold standard. And there was a systematic review in 2021 that identified 102 unique studies on parenting interventions. And they find average improvements of 0.32 standard deviations for cognition and 0.28 for language. So these effect sizes are similar to what we saw in this trial, but without the visits required from these kind of parenting interventions, just to put that in a bit of perspective. So we had we also had a chance to look at willingness to pay, and so we offered families the chance to buy SQ-LNS, and we randomized the offer. Some people received the offer of 0, just to receive it for free, and then we went up in 0.5 kwacha increments up until 3 kwacha. So we were able to then get this demand curve, and you see, 95%, a really high number. This kind of demonstrates the acceptability of the product when it was offered for free, not so surprisingly, and then it drops, but still 50% were willing to pay something. We're willing to pay half a kwacha, and 20% were willing to pay up to 3 kwacha. And so there at the circled with 1 kwacha is about, I think about around 4 cents. Okay, and just in the interest of time, moving on quickly, we also had a consumption observation, as I mentioned, and these were, we had enumerators in the home for 10 hours at a time, observing all of the child feeding practices, including SQ-LNS. And we were able to do 4 rounds at different times to try to understand a bit about seasonality. And I want to just pull out some of the highlights from that work. So we observed, so this is not self-reported, it's just from having these observers in the household, around a 67% compliance, meaning that observed the index child eating the SQ-LNS. We also saw some kind of lower levels than we expected of sharing. So only 11%, in 11% of the visits, did we see other people in the household consuming the SQ-LNS. And when children ate the LNS, they consumed the entire sachet, which is important, as Kay pointed out, about the small size of it, so that it's packed densely but isn't a large amount. It's easy for the child to consume. And then one other observation was that the children in the combined group, the ones that had the growth charts and the SQ-LNS, they were 37% more likely to mix the LNS with other foods. The last thing I wanted to point out was, based on this observation, we don't see a lot of evidence for SQ-LNS displacing breast milk. So there is, if you look at the curve, we see a slight decrease of a couple of percent, but it's not statistically significant. And so we don't see evidence of the LNS displacing breast milk. Okay. So on the next steps, as I mentioned, we have biomarkers, and so we have work to assess the effect of SQ-LNS on biomarkers of systemic inflation, EED, and the gut microbiome. We also had measured eye tracking, and so we're going to analyze the inline data on saccadic reaction time as another measure of child development. Continue to look at the diet and feeding practices, and then a lot of the work, dissemination and discussion with stakeholders on this. So thank you. I'll wrap up with that, and we'd like to hand it over to Christine Stewart. One second. So Christine is the director at the Institute for Global Nutrition and the Corinne Rustici Endowed Chair in Applied Human Nutrition at UC Davis, and steering committee member on the SQ-LNS Task Force, to talk about the great work at the task force on prioritizing research questions. So over to you, Christine.
Thank you so much, Doug. Can you see my slides okay and hear me okay?
Yes.
Great. So I'd first like to start by thanking you and thanking IPA for the invitation to present in the webinar today. It's an honor to be here. So as we heard in the previous presentations, there is clear evidence of the benefits of SQ-LNS on child survival, growth, development, and micronutrient status. And because of this evidence, many organizations are interested in incorporating SQ-LNS into their programs and scaling it up, but knowledge gaps do remain. However, the types of knowledge gaps that exist now are different than those that existed when SQ-LNS was first being evaluated for its efficacy and effectiveness. At this stage, research is needed to inform the delivery and implementation of new and expanding SQ-LNS programs. However, given limited resources and other constraints by funders, implementing organizations, and researchers, there's a need to prioritize research activities. And so that was the goal of this study that I'll be presenting today. So for this study, we adapted the Child Health and Nutrition Research Initiative method, or CHINRI. This is a method that was developed to assist with decision-making and priority setting for health research investments. It produces results for a target audience of international agencies, research funding donors, governments, and policymakers. And it uses a systematic, transparent, and democratic approach to evaluate a set of proposed research options against a predefined set of criteria. Although it was initially developed to consider research on child health outcomes, their epidemiology, etiology, and efficacy of preventive or therapeutic interventions, the Chinri method has been adapted and applied to a wide variety of potential research topics. So to use this approach, one must pre-specify what criteria against which all of the potential research options could be evaluated. So we chose to use the RE-AIM criteria. RE-AIM is a framework developed to improve the adoption and sustainable implementation of evidence-based interventions in public health and other settings. And it includes 5 elements. The first is reach. Would the research enable programs to better reach key target groups? Effectiveness. Would the research improve or provide new insights into the effectiveness or impact of the intervention? Adoption. Would the research enable greater adoption by key actors? Implementation. Would the research improve the fidelity or quality of implementation? And maintenance. Would the research evaluate or support the institutionalization or maintenance of the intervention in routine organizational practices or policies? And we elected to drop this last criteria because we felt that there were so few organizations that were already using SQ-LNS routinely that there was not yet a need for research evaluating these topics. Instead, we added an element of affordability. Would the research activities be affordable to implement within a realistic timeframe? So to gather input on potential research topics for consideration in the research prioritization activity, the 25 members of the Operational Research Working Group within the SQ-LNS Task Force brainstormed and submitted questions. Then a smaller group reviewed these questions, removed or merged duplicates, and reworded some of the questions to enable them to be better judged against the criteria. And so from this, we shortened the list to 20 questions that fell into 3 domains, 11 in the domain of delivery, 3 in efficiency, and 6 in discovery. So we developed a survey that could be administered over the web. And so the survey was developed in Qualtrics with both English and French translations. And respondents were asked to evaluate each of the 20 potential research topics against their ability to achieve the 5 RE-AIM criteria using a Likert scale. Respondents were also asked to weight how important they felt each of the RE-AIM criteria were. The survey was sent to a list of 140 potential respondents from academia, NGOs, UN agencies, donors, producers, and governments. And the initial email list was based on a list of individuals who were known to have some experience with SQ-LNS, complementary feeding programs, or stunting or wasting prevention programs. And respondents were encouraged to share the survey with their professional networks, and surveys were completed anonymously. So 2 primary statistics were calculated from this study. For each question, we created an average research priority score within and across each of the 5 RE-AIM criteria. And then we also created a weighted research priority score using the calculated mean weights that the respondents had assigned to each of the criteria. So these 2 pie charts illustrate the distribution of our respondents thus far. The majority, 44%, were from academic or research institutions. 27% were from NGOs or nonprofit organizations. 11% were from UN organizations, and 9% were SQ-LNS producers, and 9% were donors. The majority of respondents hailed from North America and Europe, 39% and 28% respectively. 23% of respondents hailed from Africa, and a small fraction hailed from Asia, Latin America, and the Caribbean. So respondents were asked to weight how important they felt each of the 5 RE-AIM criteria were. If the criteria were all equally weighted, they would have a score of 20 points each. And so you can see that these top 3 criteria, implementation, research, and effectiveness, were weighted more heavily than the criteria of adoption and affordability. Okay, so what did we find? I've pulled out the top 5 most highly ranked research topics according to their weighted priority scores. So the top topic was what criteria should be used to identify geographic regions to target for SQ-LNS distribution. Second was how can integration into delivery platforms be optimized to maximize coverage, reach, and achievement of broader health goals. Third, does incorporation of SQ-LNS into other health services incentivize utilization or participation rates in those services? Fourth, are social protection programs an effective delivery platform for SQ-LNS? And fifth, what are the main cost drivers of SQ-LNS distribution within different delivery platforms, and how can they be reduced? We also examined whether there were additional research topics that had been highlighted under the most heavily weighted criteria of implementation, reach, and effectiveness. And we found no additional questions prioritized under implementation and reach. However, there was one additional question ranked highly under the effectiveness criteria, which is shown here. Would inclusion of SQ-LNS into acute malnutrition treatment programs reduce the risk of relapse? So in summary, we recommend focusing research investments on activities that support the implementation, effectiveness, and reach of SQ-LNS programs. The research themes that ranked as of highest priority were those that considered how best to target SQ-LNS programs, and those that would evaluate how to integrate SQ-LNS into health systems, social protection programs, and wasting management programs. I would like to note a limitation of the present analysis is that we have a relatively small sample size, and we would like to keep the survey open to solicit more input from a broad representation of people who have an interest in this topic. And so we would encourage anyone in the audience to participate, and you can use the QR code here or go directly to our website, sqlns.ucdavis.edu, where we have a link to the survey posted on the main page. So I'd like to finish by thanking the many members of the Operational Research Working Group who are all listed here. And I also would like to offer special thanks to Charles Arnold and Kathryn Kwan, who conducted the data analysis that I've presented today, and conclude by thanking the Bill and Melinda Gates Foundation for their support in funding the SQ-LNS Task Force. And I'll finish here.
Thank you, Christine. Our final panelist today is Philomena Irene from UNICEF, and I will hand it over to you, Philomena.
Yeah, thank you so much. It's an honor to be invited. It's an honor to be invited to be part of the panelists for this webinar. I'll be sharing UNICEF experience in enhancing young children's diet with small quantity lipid-based supplements in Gombe State. No, the slide is not changing. Okay. Yeah, as you all know, Nigeria remains off track to achieve the SDG 2 targets because our data are in Nigeria currently over 39.2 children are stunted and over 47.3 children are anemic with exclusive breastfeeding rate less than 50%. It's even worse off in Gombe State with exclusive breastfeeding rate of 30.7, minimum dietary diversity of 22.5, minimum acceptable diet of 8.4. That shows that children are really living in chronic food poverty, and it's even worse by the climate change issues we have in Gombe State, flooding, drought, and also insecurity in this part of Nigeria. In Gombe State, UNICEF implemented the PASMIC project in 3 LGAs, which include the PASMIC project, include the system strengthening and also the provision of SQ-LNS to children 6 to 23 months. The 3 LGAs are Duku, Kwame, and Kaltungo LGA. Basically, PASMIC is It's an acronym for Progressive Action on Resilient System for Nutrition through Innovation. The PASMIC project, like I said initially, we had the enabling environment, strengthening the enabling environment, which we did through policy development, through improvement of the coordination structure, the multi-sectoral coordination structure for nutrition, through unlocking finances for nutrition at the state and LGA level, and through strengthening partnership. We also strengthened the food, the health, food, and social protection system to deliver safe, affordable nutrition diets and high impact nutrition services for women and children. And we also improve the diet and practices at household level. Basically, our program mantra was to prevent malnutrition, integrate nutrition issues into other sectors, and to scale it up at large. Like I told you, our results so far, in under strengthening creation of enabling environment, we ensured the states had state food and nutrition committee that is functional and is being held accountable for nutrition issues. It involves other ministries and agencies for nutrition. We are able to support the state too to develop Gombe State food and policy, and also the costed multi-sectoral nutrition strategic plan. We are able to unlock resources for nutrition. It is small, but it's something starting. We're able to unlock $120,000 from the states for nutrition activities, especially to improve the diets of children 6 to 23 months. And we are able to leverage partnership with other UN agency, private sector, and also foundations to ensure that nutrition issues is being put on the front burner. Basically, we were able to build the capacity of healthcare workers, train them on infant and young child feeding, linked with SQ-LNS, and also trained community-based volunteers to facilitate support group meetings, growth monitoring and promotion, MWAC screening, and also we incorporated the treatment of SAM into the program too. And in all, over 4,000 children, 6 to 59 months, we are treated for SAM. And in many places, most SAM centers were converted to full PAC, where they offer the full-fledged program for infant, for mother and child in those communities. In the diets, for diet and practices, we're able to train, we're able to provide counseling to over 18,000 caregivers on infant and young child feeding, appropriate infant and young child feeding, alongside family-led MWAC. Mothers were able to screen, caregivers, mothers were able to screen their children for malnutrition and to refer in case of where they found there is any issues, whether the child is in the red region or the yellow region. And we are able to incorporate the homestead gardening, introduction of micro gardens established by caregivers in these LGAs to ensure that they are not only, to ensure that they consume food that are nutrient rich, included in their diet. Basically, we were able to fortify the diet of children, over 15,000 children, aged 6 to 23 months, from these 3 LGAs with SQ-LNS. So I'll be presenting basically result from the case study documentation. This project was implemented over a period of 6 months in 2021. And basically we did a case study documentation. And we found out that because of the introduction of SQ-LNS into the program, we had over 300 increase in IYCF counseling compared to similar period in the previous year. We are able to record 6% reduction in diarrhea cases and 22% increase in exclusive breastfeeding. And one of the good things is from the mothers and caregivers. It was very good for us to hear feedback from their experiences fortifying diets of their children with SQ-LNS. We're able to find that, like, for instance, SQ-LNS became very popular. The acceptability was high. It was, recognized as children's fertilizer, popularly called Takiara. And mothers even said they were willing to buy if it's being sold, because they noticed the improvement in their children's eating habits, the motor skills, children complexion change, the hair color, they could notice the change. And they were just so happy and glad that SQ-LNS is making a difference in the lives of the children. Basically, too, we're able to sensitize local opinion leaders to create positive change, so that introducing the gender components into it to ensure that fathers are integrated into the caring of their children at home, introducing small doable actions to ensure that they are part of it. They are part of the parenting of their children in these communities. And by and large, we are able to see that more men were allowing their wives to come for even antenatal. There was an uptake of even other health intervention because of these services that we were providing, especially SQ-LNS, because they could relate it to the improvement in the child welfare in the home. So basically, from our health, from the health registers, we're able to notice that from the DHIS registers, like I said, comparing the similar year period, that over we recorded over, for instance, in Duku LGA, over a 200% increase in the counseling, while mothers accepting for children to be counseled, increase in increase in immunization rate. Mothers were coming for immunization, even birth registration. There was really increase in the uptake of health services by mothers, even from LGAs that were zero dose LGAs prior to this time. And one thing we want to say is SQ-LNS, what we found that is not a standalone intervention. It should always be accompanied with other messages and other intervention, especially working to ensure that there is food at home and linked with other social protection system in the community, and also and also the watch system. So what were our challenges? Well, one of the big challenges we find that the negative norms and practice was deeply entrenched in these communities, which led to chronic food poverty. Because in most of these communities, you find that children just consume just one food group, which is either a grill made from millet or maize. And there was flooding in Nigeria and in the neighboring states. And because of the high uptake or the improvements that other mothers saw in other LGAs that we were not implementing the program, there was an influx and increased demand for SQ-LNS. So it led to early stock out. And also, currently, we are not able to restock SQ-LNS because of the global shortage. Lessons learned, integration of nutrition and health services, distribution of SQ-LNS, like I said, led to increased uptake in immunization, birth registration, family planning, as mothers were encouraged to bring immunization cards during IYCF sections. There was great increase in adoption of positive practices by community leaders and fathers, with SBCC addressing harmful gender norms, and importance of initiating local production of SQ-LNS to address the shortages we are currently facing. The way forward. Currently, we are thinking of with the case study documentation, we have presented these findings to other states in Nigeria with similar geographical terrain and similar features in Adamawa, Bauchi, and Plateau states. And thankfully, these 3 state governments have committed fundings and have released the fundings to UNICEF to support them to procure SQ-LNS. We continue mobilization of resources for local production. Currently, we have 3 manufacturers of RHTF in Nigeria, and we are talking with them to the inclusion of SQ-LNS in their production line. This is in conjunction with UNICEF in Copenhagen. Also, we have already started discussing with the government of Nigeria to include SQ-LNS in the essential medicine list, and already SQ-LNS have been given a provincial approval for the essential medical list in Nigeria. So to improve the diet also, we have introduced the cultivation of climate-resistant orange flesh sweet potatoes to enhance the diet, and also sustaining the gender responsive. We continue the gender responsive maternal, infant, and young child social behavior change and positive parenting. And also we're going to roll out the complementary feeding bowl and spoon to ensure that mothers are aware of the different food groups for their children. Thank you very much for listening.
Thank you, Philomena. And thank you to all of the panelists. We would now move into a moderated discussion and question and answer session. And so the first question, I think, is directed to Kay. What is the relevance of the new WHO guidelines in enabling the implementation of SQ-LNS?
Thank you, Doug, for that question. I think it's very important that SQ-LNS is mentioned as a recommendation in both sets of guidelines, because many countries wait for guidance from WHO before implementing a given intervention. In the guideline on complementary feeding, it's recommended under the section that deals with the use of fortified products for children between the ages of 6 and 23 months. And it is recommended when there's evidence of dietary deficiencies and nutrient deficiencies. And in the guideline on wasting, SQ-LNS is one of a very small number of interventions that is listed that was found to be effective for prevention of wasting. So there are many contextual factors that are mentioned in both sets of guidelines and other remarks that are important to consider when countries think about mounting an intervention like SQ-LNS. So I recommend that people read the guidance very carefully before embarking on that.
Great, thank you, Kay. Christine, we have a question for you. What do we know and what do we still need to learn about effective delivery models for SQ-LNS at scale?
Sure, thanks, Doug. I'm happy to answer that question. So we know a little bit about the delivery of SQ-LNS within health systems. There have been a few effectiveness trials, either through community health worker distribution models or via models where the caregiver had to come to a central location, like a health post, to pick up the supplements. And these types of programs have been quite successful. The SQ-LNS has been appreciated by caregivers and by the health workers. And in fact, there's some evidence to suggest that SQ-LNS may serve as an incentive for uptake of other services, for example, attendance to community meetings or women's groups, or for uptake of vaccines. And this possibility of incentivization, I think, is really exciting. And it's being tested in a new trial called Nutravax in Nigeria, which is led by Alima with funding from ECF and Gavi. But there are challenges, though, for delivery through health systems. Increased demand for services can create challenges for program management. There have been some programs reporting staffing challenges or overcrowding, which needs to be thought through when considering integration into this delivery model. There's also been research evaluating the provision of SQ-LNS within health systems as an incentive for wasting screening and prevention of wasting. And it's really appealing to try to link the therapeutic and treatment services. But this presents some challenges if those two modalities are delivered through different mechanisms, like through a community health worker outreach model for preventive services, but through a central location for the therapeutic. So there's research needed to really think about how to effectively link these types of programs well to make sure that wasted children are receiving the services that they need. In terms of new areas of research, I think there's a lot of interest into integrating SQ-LNS into social protection programs. But there's less experience with that distribution model. And so we really need more research in that domain. There's also a lot of interest in delivering SQ-LNS through humanitarian assistance programs. And there's an important area for research as well, how to optimize the food basket that might be delivered, incorporating SQ-LNS. What is the likelihood of intra-household sharing within these highly food insecure households? And we also need to understand if shorter durations of SQ-LNS supplementation, for instance, during just the lean season, may be effective. So while there have been a lot of strides in documenting operational experiences, there's really a large need for implementation research and possibly effectiveness research using different program platforms to really understand how to deliver optimally and efficiently within a variety of country and programmatic contexts.
No, that's great. Thank you, Christine. For Philomena, could you elaborate a bit on the main challenges to integrating SQ-LNS into government systems?
Yeah, thank you so much for the question. Delivering SQ-LNS in the government system, because SQ-LNS is a new product. And most government systems, like I say, we have the essential medicine list, which SQ-LNS has to be listed as a product in the government setting and also be included in the MDC guideline in the country. So presently, these are all what we need to work, while we need to do a lot of advocacy for government to see the efficacy of SQ-LNS. For instance, like in Nigeria, they did a lot of the pilot we did in Gombe State. It was done through the government system, and they were part of the monitoring. They were part of, asking mothers of the experience in fortification of SQ-LNS with their children's diet. So they need to be part of it, part of the processes of all the researches, all the pilots that's going to be done, so there can be high acceptability. And like that's what we've been doing in Nigeria, and we have been seeing it yielding fruit. For instance, now, like I said, SQ-LNS have been given provincial approval in the essential medicine list. So if it makes it finally to be part of the basic healthcare package, so can now be listed as part of the community health insurance medicines that government can procure and provide to its citizens. Thank you very much.
Thank you, Philomena. We have some other questions that have come in through the Q&A and other avenues. And one, just kind of more generally for the group, is how people within a given country could find out about whether the government or other organizations are currently implementing provision of SQ-LNS, or whether SQ-LNS or other types of LNS are currently being produced in that country. I don't know if maybe Kay, would you have thoughts on that?
Well, I can get started and maybe others can chime in. I think I would begin by asking, for example, representatives within the government Ministry of Health that are responsible for nutrition programs if there is any current or planned implementation. But I would also check with country offices for UNICEF and the World Food Program, and if there is a country level scaling up nutrition unit. This is the SUN movement, which is active in most countries. That would be another place to ask about what the plans might be. And in terms of production, this situation is changing, I think, fairly quickly. So any answer we give right now might be out of date. So it might be a good idea to get in touch with our task force, the SQ-LNS Task Force, and we can try to coordinate getting clear answers for a given country that are as up to date as possible.
That's great. I don't know if any others want to elaborate. No problem if not. So then we have another question about supply chain logistics. So maybe Christine or Philomena, could you elaborate on the supply chain logistics for SQ-LNS?
Maybe I could start, and then Philomena could maybe chime in from the Nigeria experience. So I think the challenge right now is that there are, and I think this sort of speaks to one of the previous questions about distributors or producers of SQ-LNS. There's a relatively small number of producers of SQ-LNS at the moment. That is changing, though. But when considering how to deliver SQ-LNS within a given program, you need to think about procurement timelines and where the product may be coming from, and whether there's a need to import the product into your country. What are the regulatory considerations within a given country for product imports, if that's necessary, and then thinking through the time frame for production of the products, as well as shipping and then in-country transport to the location where the programs are being implemented. And so all of those kinds of logistical considerations need to be factored in, as well as safe storage considerations once the product is available at the program site. The SQ-LNS Task Force is working on an operational guidance document that we have nearly ready to share. And I think that will help program planners kind of think through these issues about logistics and timeline and procurement and so forth. So I'm speaking kind of in generalities. I don't know if Philomena, if you might have anything to add from your experience in Nigeria.
Thank you so much, Christine. I think you've really summarized it very well. The logistics for SQ-LNS is a little bit, I think globally, we have challenges. That's why, like in Nigeria now, we have three known producers which have been accredited by UNICEF to produce RTF for treatment. So UNICEF is currently working with them to see how they can produce SQ-LNS in country. This is a long time thing. It's not going to be very short in a short while, because it takes a long time to get approvals from the government, from quality control and all that stuff. So that's what we are currently doing while we are sorting for SQ-LNS from overseas through our office in Copenhagen for the production of it. So basically it is, I think it is what it is for a good product. You get this kind of challenge. The demand is more than the supply right now.
Okay, well, thank you all. I know there are more questions coming in, and we'll try to get responses to those. But we are at the end of the webinar. I would just like to kind of finish up with what a call to action. And so, if for funders supporting the SQ-LNS implementation research and scale up activities. This includes IPA's continued work in Zambia, but also the research agenda from the task force and many members that are working there. And there's also the Child Nutrition Fund. So the Child Nutrition Fund is a new financing mechanism designed to accelerate the scale up of sustainable policies, programs, and supplies to end child wasting, including distribution of SQ-LNS. So that's one to look in, and we put the link here when you have the slides. For implementers and policymakers, invest in SQ-LNS programs. Consider applying to the Child Nutrition Fund and advocate for increased funding and support. And finally, for researchers in this space, reach out and consider joining the SQ-LNS Task Force and focus on research that supports implementation, effectiveness, and reach of SQ-LNS programs. And so I would like to thank everyone for the questions and for participation. Especially thank you to our panelists. And for the organizers of this event. I really appreciate everything, all of your experience and wisdom. It was very informative and useful. I hope everyone thinks the same. So we will follow up with sending out these slides from the webinar, and please feel free to contact us if you have any further questions.
Yeah.